something a lot of people know about or they've experienced, but not really had an opportunity or a forum to ask questions about treatment, et cetera. And so our ideas for Promise Day come from you, the student, and we really encourage you to reach out to us and say, hey, next time, could you discuss? And that helps us. I am particularly touched and honored to present today's speaker. Mary Miracle is a dear friend of mine, and like the sister I never got to have. I met her in graduate school at UNC. We were both training to become counselors. And Mary has this positivity, this dynamic personality that is a healing light for so many who seek her services. And so when we're talking about a topic as difficult as child abuse, who better to ask than a dear friend who I know works with children who have been in this situation. She has worked for over 10 years and has brought myriad experiences, by the way. She actually originally focused on eating disorders and then shifted gears a bit. And I was absolutely fascinated because my counseling training was working with adults. And so I was always fascinated to hear her stories and what it was like to work with young children who had been in foster care in different situations. So I'm going to turn over to Professor Paige Roseman, and she will ask some of the questions that have been sent. So thank you, Mary, for coming today.
Of course. I'm glad to be here.
Yes, thank you so much, Mary. We're absolutely delighted to have you, and we're delighted that we have students who are here and who are able to chime in and to comment. So students who have joined us, just so you know, we have set this up with Mary's permission as a bit of a question and answer session. And some of y'all know, because you submitted questions that you would like to ask of Mary, our licensed professional counselor, in thinking about her work. So we wanted to start with a really important question, and we may or may not get to all of the questions, but we will also do our best in the time that we have. So one question that came in from y'all was, what long-term issues does a child face when they have gone through abuse and or neglect? So thank you, Mary, for kind of starting us off strong with this one, and we'll continue.
Yeah, I think that is such a complicated question because, obviously what is the case for one person might not be true for another person. And so some of I think of this question in two different parts. I think of it from an attachment theory part and from a brain development part. And there's other factors involved. But what we know about the brain, and now, I am not a neuroscientist, so, don't quote me on all of the little scientific specific terms, but our brains are very use dependent. And so what happens in childhood is that when your brain is kind of being wired and all of that neural pruning is happening, that what we use is the pathways that stick. So when you are in a constant fight, flight, or freeze state as a child, that is kind of, your brain can get stuck in that state. Those are the pathways that develop the strongest. And we know that cortisol is neurotoxic. And so that has effects on the brain and how they develop. There's some data out there about PTSD, and I haven't looked at this one specific study in a while, but like brain scans show difference in hippocampal volume and different things like that. And we're not sure of, like, it's a chicken or an egg kind of thing, right? Are people with reduced hippocampal volume more likely to develop PTSD, or does trauma cause that? And so the other part of that is attachment theory. So there's a huge difference in, first of all, simple versus complex trauma. Did you have one experience with abuse or neglect? Was there one incident where, as a child, a daycare provider physically assaulted you? That would be simple trauma. Or complex trauma, which is chronic ongoing trauma. And with that, was it a caregiver that was abusing you on an ongoing basis, or was it someone who wasn't your primary caregiver? And because I don't know how much you guys talk in your classes about attachment theory, but that bond that you have with your primary caregiver is really how we learn about ourselves and the world and other people. And trauma is particularly damaging when it comes from that attachment figure, from that primary caregiver. Because and that's true of both abuse and neglect. That's how we learn to regulate our emotions, and it can do a lot. The other thing to think of is we were talking a little bit earlier about the ACE study, and I know some of your students are familiar with that. And so what that ACE stands for, adverse childhood experiences. And so things, I forget the exact short list of them, but childhood abuse, neglect, substance abuse in the home, domestic violence in the home, divorce, a parent being incarcerated. And what the study found is that the more ACEs you have, the more likely you are to have negative health outcomes. And I have some of them here. I can read some of them off. Alcohol and drug use, COPD, depression, heart disease, liver disease, financial stress, suicide attempts, teen pregnancy. And some of that is thought to be like physical effect of trauma, but then also increase in risky health kind of behaviors like smoking, increased rates of substance abuse, having multiple sexual partners. I know that was a lot of information. Does that answer the question?
I think it does answer the question really well. And I know that there are lots of folks who are sharing in the chat just their names so far, just kind of signing in. But y'all are welcome as well to put some questions and comments in the chat as we go. I really appreciated, Mary, that you connected back to thinking about, especially for children, the kind of power of that brain development, what's repeated sticks, thinking a little bit about simple versus more complex traumas, which folks may or may not have heard about, especially in their intro psych courses. And I know there are folks here from upper level courses as well in abnormal psych with Dr. Mack. So yeah, I think that really helps. And I think in particular, the way you speak about it is so clear that it helps us kind of be able to think. So
a large part of treating most things, but I think especially trauma, is psychoeducation. Is, there's a saying, it's not what's wrong with you, it's what happened to you. And I think that having people understand that it makes sense why these things are hard for you. It makes sense why, you hear someone yelling, you hear a loud noise and you freeze up, or you get super angry and aggressive. It makes sense. It's something we can work on.
I love that. And that really kind of beautifully leads into thinking about different forms of therapy. And if you would be willing to just kind of speak with us about that, I'll give you a couple of other of our questions. We have lots of different sets of questions here. And specifically, students are really interested in what is trauma-focused therapy and what is the advantage of trauma-focused therapies over other forms of therapy.
So I have a really interesting statistic here about, and I believe this comes from the National Institute of Mental Health, that 3.5% of adults and 4% of children ages 13 to 18 have a diagnosis of PTSD. And of those, only 49.9% are receiving treatment. And the part that really, really gets me is of those 49.9%, only 42% are getting adequate treatment. And so I think there is such a need for providers to be trauma informed, because when I think of trauma focused therapy, I mostly think of trauma informed. And that can be little things about, like, like I said, asking what happened to you, not what's wrong with you, the way you set up your office and the waiting room, the way all of those policies and procedures work is kind of a trauma informed practice. And there's a big push in the mental health community towards trauma informed care. But I think, in terms of trauma focused therapy, there are a couple of gold standard evidence-based practices for treating trauma and PTSD. And the big ones, there might be others I'm not mentioning, but the big ones are EMDR, which is becoming very popular. For adults, what's called trauma-focused cognitive behavioral therapy, which I have some pretty extensive training in. And something for adults is called cognitive processing therapy. And TFCBT and CPT are very, very similar. And just one is geared more towards kids and more towards adults. And really at the heart of that is, and at the heart of all three of them, is getting people to be able to talk about the trauma. Because what is really, like, what makes, one of the things that really makes you sick with PTSD is the avoidance. People do all of these things to avoid thinking and talking and feeling those feelings. And because of that, they have intrusive thoughts, they have nightmares, they, all of these different things. And to really, the goal of treatment is to get people talking about the trauma, but also being able to reprocess the trauma, being able to identify those thoughts that are keeping them stuck in it. And sometimes those thoughts are, this was my fault, the world is unsafe, this bad things happen to bad people, this must have happened to me. Some of being able to identify those stuck points, they call them in CPT, or cognitive distortions, and change them. And that can be a really powerful thing.
I think the idea of identifying those stuck points and helping folks get to the point where they can speak about trauma is really powerful. And I think there have been a couple of kind of questions floating in, so I will speak these aloud and then kind of bring them in and connect them to what we're talking about. So one question that sounds like a little bit of what's happening in the chat is, and let me scroll up really quickly. This is from Julie. Would we approach discussing a patient's trauma with them if they're not willing to discuss it currently? So I guess this is someone, thinking specifically about how do you, as a therapist, help folks kind of overcome that challenge?
So every case is different, right? And I was trained that nobody is too traumatized to be able to talk about their trauma. And there's also a statistic, and I forget what percentage, but a lot of people never disclose their trauma because they're never asked about their trauma. And so I make it a point to always ask people if they've ever, experienced any type of trauma. But with that said, there's a lot of loss of control that comes, or feeling of loss of control that comes with trauma. And so I always let people know that they are the ones in control of, like, they can always, I'm going to ask them questions. They have the right to say they don't want to answer it. And, a lot of psychoeducation about avoidance and the harm that does. We also do a lot of gradual exposure of, like, I am not going to have you come in on your first day of treatment and discuss in vivid detail your worst trauma memory. That's going to be really, really overwhelming, and you're probably never, ever going to come back and see me. So a lot of just like dipping your toe into the pool instead of jumping in head first. But I let people know that this is the goal of treatment, to be able to talk about this. And don't underestimate the importance of a relation, that strong therapeutic relationship, making people feel trust and secure and heard.
I appreciate that you mentioned the power of that dynamic of trust that you set up and that kind of healthy relationship and set of boundaries, that gradual exposure as well. I think that's all really powerful to think about, especially if someone is at the point where they feel like they could benefit from actually speaking that trauma aloud with a professional. I think that's really powerful. So intimately related to this, there are lots of questions in the chat that I'm going to try to pull back to our original set of questions here too. I would love for you to just speak with us a little bit, and this is a tough question, but it's related to some of what we're seeing, about what happens to folks. I'm just going to read this verbatim, but we'll connect it here. What happens when kids do not get therapy for abuse and then they grow up? A big question that you've addressed earlier is ACEs and some of those health outcomes. And in particular, folks really are interested in whether they go on to repeat that cycle of abuse. And there have been several questions in the chat about what we can do to kind of break that cycle of abuse. And I imagine getting therapy.
So getting into therapy is the biggest thing. And again, I don't know the numbers on this or the statistics, but the sensors on my lights are all wonky. So if you see the lights turn on and off, if you grow up in a household where there's domestic violence happening, you're more likely to be in an abusive relationship yourself or be the abuser in an abusive relationship. If there is a cycle of abuse where, I see kids who have been sexually abused, whose parents were sexually abused, whose grandparents have been sexually abused. And then on the flip side, I have seen parents who are so hyper vigilant about their kids, they experienced abuse and they're so hyper vigilant about their kids being abused that they go to great lengths. They don't let their kids do, they do daily genital checks on their kids or things like that are pretty extreme that aren't the most helpful things. But getting into therapy is the biggest piece of advice I can have.
If I could just come in, you were mentioning the genital checks. It seems like there's potential trauma from parents who are trying to avoid their child going through trauma, is what it sounds like.
So sometimes, I don't want to speak broadly for everyone, right? Like I don't want people to hear you're going to mess your kids up if you have experienced trauma yourself, because that's not the case. I know a lot of parents who have experienced incredibly traumatic things who are very determined to do differently. And it's not always quite that easy to just decide to do differently.
Gotcha. Thank you. And Paige, what else did we have in the chat?
Yeah, we have a couple of questions in the chat. And I thought maybe because we got to talk a little bit about more 3 different types of trauma-focused therapies, but we didn't get to talk as much about play therapy. And I thought maybe circling back to that might be helpful before we jump into the chat.
So with play therapy, there's 2 different kinds of play therapy. There's directive play therapy and non-directive play therapy. And directive play therapy would be like, okay, I have this specific playful intervention that I am going to do with you. Like I have feelings Jenga I play with kids in my office where there's different feelings written on all the Jenga blocks. And every time you pull one, you have to tell a time you felt that feeling. Activities like that. Non-directive play therapy is more like just child-led, you follow them. And I'm not a registered play therapist, but I've done some training on it. And the idea behind it is that play is the language of kids, and that is how kids communicate. And so you're learning how to, in going through play therapy training, you are learning how to listen, understand that play. And I know one of the questions that had come in beforehand was something along the lines of, how do you keep it from being just play? And someone who is very much a non-directive play therapist would challenge you on what you mean by just play, because play isn't just play. Play is very powerful.
I appreciate that you mentioned that, because I think as adults, it's hard to kind of enter that world of a child again, and the mind of a child, and to think about the benefits of something like play.
It is. And sometimes for kids, especially kids who are feeling really powerless and out of control, just to have them come in and say, hey, you're the boss in here. You can pick whatever you want to pick to play. Do you want to help me clean up, or do you want me to clean up? Do you want to play with this over here or over here? Is really, really powerful, because I mean, as a parent, you can't do that at home, right? Like, you have to have more rules and boundaries.
Yeah, absolutely. And I think too, I really appreciate you sharing with us a little bit more about the play therapy, because some of the other trauma focused therapies, it sounds like we're more geared towards adults, right?
Yeah,
there's different versions.
The TFCBT, the trauma focused cognitive behavioral therapy, is, it is very playful the way you do that. You know, I use feelings Jenga in that, you know, whenever you're working with small kids, it has to be playful. A 4-year-old isn't going to sit on the couch and talk to you.
Absolutely. And that reminds me too of kind of bringing together different approaches from your training, right? Whether you call it this or you call it that, you bring together many different elements that suit the individual that you're working with.
Absolutely. And that's one of the things I really like about using TFCBT is it is a structured model, but it has flexibility in it. It is not like in session 1, you do this, in session 2, you do this. This is the component that we are working on, and I'm going to pick the activities that work best for this kid under that component.
Yes, absolutely. I like that structure with flexibility.
I noticed a question come in that I would like to touch on quickly. Someone asked about how do you help someone to recognize a traumatic event that they don't think was traumatic? And I just want to say, trauma is very much in the eye of the beholder, that 2 people can go through the same thing, and one person can see it as traumatic and one person might not. And so you never want to tell, especially a kid, that, well, this happened and you should be traumatized by this. So one of the criteria for being able to do TFCBT with someone is that not only have they experienced the trauma, but they are symptomatic. And so one of the examples when I was in training for this that somebody told was that they were doing forensic evaluations, and they had a kid come in because the babysitter had confessed to sexually abusing the kid. And, you know, again, this wasn't my case. I don't know all the details, but the kid was like, wait, no, that wasn't abuse. You know, they were just tickling me, or like they didn't see it as traumatic. And so you would never want to tell someone, well, this happened to you, so you must be traumatized and you must need to process it.
That's really interesting too, to think about like how individualized that becomes. Like, you have to understand the entire context of the situation and piece together the information to be able to really move forward.
And yeah, how the person interpreted the event that happened is really key. And now, of course, in that case, I would keep an eye on that.
Yes.
But you wouldn't want to automatically jump into well, you must have been traumatized.
And for the 281 students, I just want to jump in. Remember, we talked about iatrogenesis, that sometimes in the therapeutic process, inadvertently, we actually can cause a bit of an issue if we word it or approach it a certain way. So this is why that approach is so important, and that subjectivity has to be recognized. But the textbook heavily talks about that we have to be careful how we ask someone something happened, because if we say, when this horrible thing happened to you, we're planning the idea, versus if we say, do you want to talk about something? So thank you. I wanted to jump in because that was going to be on the final. So your timing is beautiful.
I always ask people, have you ever experienced anything that you consider to be scary or traumatic? Because there also might be something that I would, and now the DSM has very specific criteria of what constitutes a criterion A trauma for diagnosing PTSD. But it's doesn't mean that there can't be a stressor outside of diagnosed PTSD that someone considers traumatic. And something, it's up to interpretation.
Thank y'all. It's so good just to have your backgrounds and your experience as we think through these really difficult questions, because I think these are questions that, are not just on our minds and on the folks that are here, but are on lots of people's minds, right? These are larger questions. So I am curious. There are some really specific questions that we have in the chat as well we can jump into, but I would love for you to speak just from a professional standpoint about how you, I guess the best word used in the question is compartmentalize, but really what we mean here is how do you kind of separate what you hear at work from your personal and home and or family time, thinking about kind of more about your profession and how you're able to continue to be a healthy counselor.
For me, it is creating a physical boundary. I only do work in my office. I don't do notes at home. I get them done while they are at work. I might, respond to a scheduling email here or there at home on a weekend, but I need that separation that I know when I walk out of my office at the end of the day, I'm not carrying that with me. And, with that said, of course, I go home and think about all of my patients and wonder how they're doing, wonder how past people are doing, worry about people. But I'd like to be able to have that physical distinction to help me separate the two. Claire, you might not even remember this, but when we graduated, you gave me a bracelet with what you said was my biggest strength on it. And when I have those days where I feel like, oh my gosh, what am I even doing here? I have no idea what I'm doing. I'm not making a difference. I wear that and I have that reminder of, I have this thing that, like, it doesn't matter the skill. Like I care about people. And you said heart was my biggest strength, and I care, and that makes a difference. And so having little things like that, I save cards and pictures and things like that that people give to me to be able to look back on when I'm feeling like, oh my gosh, this is so heavy and so much, to be able to see the difference that I'm making in people's lives and just really hold on to those things. And when I see a new person who's really struggling, to know that I can't control that bad things happen to people, but what I do have control of is helping them to get better and heal from it.
Thank you so much, Mary. I love y'all's connection, you and Claire, and I love thinking about just the power of that. Like, it seems like a theme that we keep coming back to is that locus of control, recognizing what's in your control when things are really bad and you cannot necessarily control what's happening out there, to be able to still positively influence people's path towards resilience and towards healing. And I think oftentimes this happens in smaller moments than you would think, right?
Absolutely.
And helping empower other people to have these conversations with friends and family members too. So there are lots and lots of questions. But one recommendation, it looks like some folks are putting in some recommendations around ACEs and healing too, which is very good. So One other kind of related question that had come up in the chat, and I was curious because I think, this would be a great space to share if you would. And there's a lot of questions, so I'm going to have to scroll. But someone was asking about how, what kind of recommendations you have for finding a therapist or for finding a counselor.
Oh, that's such a hard question, because there are so many therapists are so full right now and have wait lists. And then even when you find someone, finding someone who's the right fit for you is really hard. So I think getting recommendations from family or friends can be helpful. So with the TFCBT, the evidence-based practice for kids who have experienced trauma, there is a roster. If you go to, I think it's the North Carolina Child Treatment Program, their website, there's a roster of people who have gone through their training. I'm one of them. And I would want someone who has specific training on that. There also, people can get lists of providers from their insurance companies. A lot of providers are out of network with insurance. I see a lot of people asking on different Facebook, local Facebook groups, but I would really start with the people who know you well. And, if you have a close family member who they have this therapist who has worked well for them, I'd start with that person.
Thank you. So thinking about those recommendations from people in our lives that we may have, also thinking about the credentials of the person that you're looking for, and then your personal fit with them as well. I think this is all obviously made much more challenging by thinking about access to healthcare and access to insurance. And
that's a whole nother discussion.
Right. That's just outside of the realm. And one reminder too, for everyone who is on the call, is that at Wake Tech, as part of our team, we have wellness counselors on staff who will provide, I think it's either 3 or 4 sessions. It's a very short-term focused therapy that's available, but they can also connect folks, including students, with community resources, so they can help you connect with a long-term counselor as well. So there's a very high need for that. Go ahead, Claire.
No, I just wanted, one thing I wanted to mention, don't worry about if your therapist who works with your family member is going to talk about you in session. They are not supposed to. So, Mary, if you want to reassure them on that, because I think sometimes people are worried about, and we've even had it when we've done referrals for students, and we keep trying to explain, no, the counselors are not going to reach back out and tell us about that conversation, because there are such strict rules behind it. So
there are, and people take HIPAA very seriously. And now there are certain things, like if I am seeing an adult, I would not also work with their husband, right? That's too close. They're going to be talking about things that come up in their relationship. And for me to be as objective as possible, I just don't want to be in that situation. And I think most therapists would probably agree. There's some, if you work in a really rural environment, that's not always an option. I don't really like to see siblings for that reason also, or, a parent and a child. But adult siblings, I think, who are living in different households, or I have a lot of people that I see that are friends. I do not talk about anything. I won't even acknowledge that I see the other person.
Thank you both for including that, because that's something that, without that clinical or counseling background, it would be tough to know, all of the roles that govern that relationship. And it builds that trust too, right? Knowing that you can, in fact, be fully honest there as well. So, There are a lot of questions, and Mary, feel free if you've seen some that come across, if you would like to jump into them. There's one that came up most recently, which is more about your background and training and how you approach meeting with your first patient while interning. So that's a little different than the rest of the questions.
I think it depends on the setting that you're in. You're going to have a supervisor in your internship that can help you through that. But I think the biggest piece of advice I would give someone is to just be human. Recognize that you are flawed. And I think showing up in session and like, you're not going to know everything. You are brand new. This is your first person that you're meeting with. You're not like, you're there to learn. You are there, and not just from your supervisor, but from the patient sitting in front of you. Just be there to listen.
That's really powerful advice. Very, very powerful wisdom.
Recognize your own flaws and your own humanness.
Speaking of that kind of topic, it seems like there have been a few folks who have asked about, and this was something that from the questions that have been compiled before as well that students had submitted, just thinking about kind of what happens when you come across a counseling case that's really, really difficult, a kind of worst case scenario. Daniel Williamson's here says, what do? Do you research and read on it? Do you get someone else to help? Do you transfer it to someone? And that fits in or kind of dovetails pretty nicely with some of the questions that folks had about just thinking about kind of a worst case scenario and how you might approach that. The flip side to that, if you're willing to also go into that, would be a kind of best case scenario in counseling.
I mean, I think it depends on what you mean by too difficult. If it is outside of my scope of practice, the ethical thing is to refer out, right? So it is outside of my scope of practice and something that I really don't want to do, to work with sex offenders. Not my thing. I'm going to refer you out. And there are other things like that too. I'll treat OCD, but OCD, I am not an OCD specialist. And if you are coming to therapy and your main concern is your OCD and it is, to a certain level, I'm going to refer that out because I feel like that's outside of my scope of practice. If you're talking about someone's trauma history being too difficult or too traumatic, I can't think, like, that's, you can't really compare types of trauma like that. I have heard some pretty awful stories and nothing really, I have a pretty high tolerance at this point to hearing stuff. So if it is like someone whose trauma is too upsetting, I don't think there is such a thing. But if it's outside of my scope of practice for whatever reason, I'd refer out. What was the second part of that question?
And the second part, which is actually really a totally separate question, I think, is thinking about a kind of worst or best case scenario in counseling sessions. And I think folks are really wondering, perhaps they're wondering about how you work with people. And, you don't have, obviously you're not allowed to share with us specifics, but you might actually have some ideas that pop to mind of kind of best case scenarios or scenarios where you see a lot of healing and growth and potential, and others where not so much.
Yeah, I mean, I think you just said it right there. Like the best case scenario is when kids get better. And I've worked with lots of kids. So with TFCBT, you do pre-treatment assessment measures and post-treatment assessment measures. And one of the big ones that you do is called the, oh my God, can't think of the name of it off the top of my head, and I do it all the time with people. The UCLA PTSD index, that looks at trauma symptoms and the intensity and frequency of them. And so when at the end of treatment, when I re-administer that, when I see people's scores significantly decrease, I mean, it's the best feeling in the world to know that I played a role in that, that because of the hard work that we've done together, this kid no longer meets diagnostic criteria for PTSD. It's incredible. And so we'll always have a little party to celebrate at the end. And that's a lot of fun to see. And I think, worst case scenario is when someone drops out of treatment and I never hear from them ever again. That's hard because you're just always wondering what happened. When you find out that when you find out details later that you didn't know that would have affected how you had done treatment, that can be really difficult also.
There's a question, if I can jump in, that it was so high up in the chat that I just want to make sure it got listened to, because I thought it was really interesting. Is it true that you have to forgive someone to heal?
Define forgiveness.
And that may be the first way to start with that.
Yeah, I would say, what do you consider forgiveness? Do you have to have that person over for Christmas dinner? No. Do you have to like that person or want that person in your life? Absolutely not. But I think to be able to get to the point where that anger is not consuming you anymore is important. And so I think, I wouldn't call that forgiveness. But if that's what someone's definition of forgiveness is, then yeah.
I think that helps a lot. And I think it's really powerful. I really appreciate the way you kind of keep bringing us back to the definition. What is it that we're looking for, and being able to articulate that, because that speaks to a lot of what you do, which is to educate folks and to be able to think in ways that are really helpful for processing these challenges. So there are a couple that I see coming in, a couple of questions. And this might actually be a pretty good one to end on, because we're getting a little close to time here. But if you are willing, Mary, Vanessa Fontana says, what kind of measures do you take to care for yourself? We did speak a little bit about that kind of balance and the things that you do to try to kind of compartmentalize a bit. And specifically, Vanessa says, how do you keep from getting burned out in this profession?
I mentioned having the cards, the pictures that I hold on to look back on hard days, to know that I'm making a difference. I have a 2-year-old and a 5-year-old at home. So, I don't know how many people have experience with small children, but it is hard to think about all of the other stuff when I am in the throes of parenting. I think being mindful of my caseload, being mindful of just myself and my emotions, and I'm feeling kind of burnt out. I think I, need to schedule some time off, or I need to, have dinner with friends, or I think being self-aware is the most important part, because burnout is real. And vicarious trauma is very real as well. And I will say that, again, going back to just being aware, I see stuff come up in my own parenting all the time that I recognize as vicarious trauma. Certain things that I feel really uncomfortable with, that, I need to ask myself, is that a helpful thing to be concerned about? Is that something, you know, what's the risk versus the benefit, and just be self-aware.
I love that you mentioned too that self-awareness piece and coming back to figuring out what it is that you need to be able to reset and to continue to maintain those healthy boundaries and to take good care for such an intense profession.
Yeah, and I think also having a variety in my caseload. I would not want an entire caseload of people who have experienced trauma. Claire mentioned earlier that working with eating disorders is another one of my specialty. I would not want an entire caseload of eating disorders. I wouldn't want an entire caseload of people struggling with thoughts of suicide. Having that variety is helpful.
Makes me think about coming back to knowing yourself, right? Because I imagine that for each person in the profession, that answer is a little different.
Absolutely.
And in different seasons and stages of life, like you really mentioned, that having young children at home in some ways really captures your attention and helps you to be fully present in your family and home space. So that's really powerful to think about as well. And I have wrapped up the kind of questions that were submitted previously, but there's still lots of questions in the chat if you have a few more minutes.
Absolutely, yeah.
So there are lots of questions like more generally about the signs of abusive relationships and getting people help. And that was from Ashley, and common forms of abuse too. So these are...
In terms of signs of an abusive, oh, sorry, I didn't mean to cut you off, Paige.
Oh, that's okay.
There is something that I use with people, and you guys can Google it. It's called the power and control wheel, that shows the different components of an abusive relationship. You know, I hear the term abusive relationship thrown around a lot, and it kind of feels like the new thing to say. And so again, how do you define an abusive relationship? That is really kind of blurry. Obviously, if your partner punches you, that's physical abuse, right? And I think that is a pretty clear thing. If your partner sexual assaults you, if there's anything physical, that's pretty clear. But the control and the emotional abuse, I think, are a lot blurrier.
Thank you so much, Mary. And I think too that Claire and I, we've gotten to be part of Promise Day events for a while. And so we've gotten to kind of have a common language around the power and control wheels. And we actually do have an event coming up next Tuesday, which we'll talk more about at the end, where we're going to talk about conflict communication, setting healthy boundaries. And this all goes back, like you said, to those wheels of power and control, and really understanding different forms of abuse, understanding those dynamics in relationships. And I think that's really powerful. So thank you for connecting so neatly back to that.
Yeah. I just saw a question come in about my internship and was I able to pick the patients I worked with. I did so when we were in school, we could pick where we did our internship. And, you know, like there's some, you didn't just get to pick your first choice, you know, there was a process for getting accepted. But I did my internship at UNC Hospital in their eating disorders program. So their inpatient unit and their partial hospitalization unit. So in that sense, yes, I got to pick everybody I saw had an eating disorder. There wasn't, within that, you know, there's so many things that are comorbid with eating disorders, right? I don't think anyone was, you just have an eating disorder and nobody else. But I was assigned patients. And so, you know, my supervisor wouldn't have assigned me something that was completely out there. But I also think that is I very clearly remember my first patient ever, and she was very medically complex and had a lot going on. And I think I learned so much from just being thrown in the deep end of the pool like that. But I saw all kinds of things, but I couldn't say, well, I only want people with sexual trauma or things like that. But it probably just depends on the setting that you're in.
And it looks like a related question is around advice for those of us who are considering pursuing a career as a counselor / therapist.
Like I said before, be human. I remember once, it was a long time ago, I was probably still provisionally licensed. And I had someone who, was struggling a lot financially, with a lot of things. And they were like, I just don't have anything together in my life. What's wrong with me? And I said to them, like, I took my shoe off and showed them how the sole of my shoe was coming off. And like, you think I have it together? Like, I can't even, find time to go get a new pair of shoes. I have all of this stuff that I'm struggling with. And just to really like show up and be human and meet them on that level. And like, I'm not perfect either. There are things that I struggle with, and that is okay. I use a lot of like examples from my own personal life in therapy, and in appropriate ways. I'm not going to dump my stuff on people, but just I think it's really important to let people know that I'm human too, that I am flawed, and that is okay. I don't know everything. I don't have it all put together. So just embrace the things that you are struggling with, embrace all the ways that you don't feel confident, and acknowledge those things. It's okay to say to people, you know what, I'm really not sure about that.
That's wonderful too, because that always makes me think about areas for growth and acknowledging that, right? And to do that, we have to be willing to accept those areas, right? And Julie says, I love that response. Thank you. So I am really curious too. I know that we've got probably a couple minutes left, but we're nearing the end of our time together. Is there something that you would like to share with all of us that you feel like, through our myriad of questions we haven't asked you about yet?
It sounds like there's several of you guys who want to be therapists. And I just want you to know that this is the best job in the whole world. I had dinner with some friends recently, and they were talking about their jobs and how they've never had that feeling of like loving going to work. That like their jobs are fine. They show up, they do what they're supposed to do. And I just couldn't relate to that at all. Of course, I would rather be at home with my kids right now. Of course, I'd rather be in my pajamas watching a movie, right? Like work is work, but I really love my job. I love getting to know people and what makes them tick and seeing the progress that people make. And I mean, I get paid to hang out and talk to really cool people all day. And it's a great job to have. It's an amazing thing to do.
Awesome. That's so encouraging. I love to hear it. And I think for many folks on the call who are interested too, we really appreciate that not only have you been willing to answer questions specifically about your training in different forms of therapy and best and worst case scenarios, but just the power of your own experience and being willing to be an example and to lead in that way. Mm-hmm. That's really powerful. I did want to take a quick minute because I've seen a couple of these kind of reminders come up on the screen. And thank you for our amazing tech team and Malik for doing everything that you do. So we have an amazing care team here, actually organized through the Care Center, and you'll see that come across the screen as well. This is a team of folks who support students and faculty here at Wake Tech. So I mentioned earlier the wellness counseling. Through the Care Center, you can find links to access our wellness services, and that's really powerful coming up on the screen as well. Our Title IX office is here to protect and support in any cases of sexual assault, also against discrimination. Their office does a wide variety of things to support faculty and staff and students. So just a reminder that, if in this conversation, things have come to light and you feel like you could use and be connected to a counseling therapist, that myself, Professor McElvaney, we are more than happy to refer you, but you can also, as a student, directly self-schedule with those offices and people to support you. So just a reminder that we do have awesome resources here on campus and that we can try to help connect you to community resources as well. And Claire, feel free to add in on that note too, anything that I might have missed or
you've got the care center up, and I really hope students will look now. Don't wait until you have a crisis or a problem to look and see what resources are available, because in that crisis moment, we have trouble remembering what is there. But if you look now and you bookmark it now, you will already know there is a group that can help you with food, emergency housing, etc. So go ahead, have it bookmarked, and whether it's for you or a friend, that way you're ready to go. I really think that's important.
Thank you so much. I agree, Claire. And there are also some messages coming up in the chat saying how much they appreciate you, Mary. So thank you for being here.
Of course, anytime.
Yes. We do have, just so that everybody remembers as well, because this has come across the screen, around the same time, but a little earlier, next Tuesday, 9:30 to 10:30, we are facilitating a second Promise Day event. And this is around conflict communication and setting our boundaries, which really goes back to some of what we had talked about today as well. So that is that's North Campus, Building H, room 395. And that is from 9:30 to 10:30, again, next Tuesday. So a little earlier than today.
And I just want to mention that will not be live streamed because of...
Sorry, I can't hear you, Claire.
It is me with technology.
Oh, okay. All right.
Because of the nature of that discussion, use of the power wheel and some different prompts, it will not be live streamed. So that is in person only. We will send that information out to everyone.
And I do see a lot of thank yous coming in the chat. And I see Laura Bethe, one of our amazing Title IX ambassadors, also in our chat. We are so grateful to have good questions and to have had this opportunity. So thank you, Mary, for gifting us your time.
Of course.
And I will, let's see, this will probably, this session will wrap up in the next minute or so. So we'll just hang on for just a second. Lots of thank yous coming in. Some folks who say they'd like to attend the next session. And I'm so glad that we were able to provide this space.
And Paige, I know you're going to wrap things up, but thank you again, Mary. We really do appreciate it.
Yeah, thank you.
It's a lot of people don't realize it's very hard for a therapist to carve out an hour, but trust me, it takes a lot of effort and rearranging for her day. So I appreciate it. And Paige, I'll let you finish up.
Yeah. Thank you so much. Thank you, Mary. Thank you, Claire. We appreciate everyone who is on this call and who was able to participate. And again, if you do have questions and or would like for us to connect you to resources, we are here. I am PL Roseman at waketech.edu. And there are lots of great resources here to support you. All right. Thank you, everybody.